Hello my dear students, my friends and to all the viewers. I am Dr. Santosh Patil, Professor, Department of General and Minimal Access Surgery. Today I will be addressing a topic on surgical site infections. The contents of this class will be the definition of surgical site infection, the physiology that prevents surgical site infection, and the sources that cause surgical site infection, and the causative organism, the organisms that are responsible for causing surgical site infection. Very important because asked plenty of times multiple choice questions. And the types of wound infection, what at different level, it will be a skin level, it can be muscular level, or it can be organ specific level. And the classification of wounds, what are the different classification, like patient can be an elective case where it's a clean case, or it can be a contaminated case when a patient comes in an emergency situation. So the patient post-operative operative recovery depends upon the type of the surgery as well. So classification of the wounds is very important, and post-operatively there are certain gradings that has to be addressed. By definition, it is growth of an organism in the wound. So there is an organism as well as there is a tissue reaction. That means that some tissue changes that are occurring. By definition, a bacterial count that is in the wound more than 10 raised to 5 organism per gram of tissue, or and there is associated tissue reaction. The tissue reaction usually is in the form of a collagen degradation and destruction of surrounding tissue of a previously normal tissue. Means the wound is in the process of healing, and slowly the bacterial translocation or infection sets in, and the tissue which is in a healing process usually gets degraded. So again, by definition, depending upon the number of days, anytime from 0 to 30 days after the operation, we term it as surgical site infection. Or if any prosthetic materials are used, like implantation of a foreign material such as mesh, vascular graft, or prosthetic joints, the definition broadens. That is, definition usually goes to 1 year. So it's very common. Surgical site infections are very common compared to other infection like urinary tract infection, which constitutes about 33% of nosocomial infection. Means any patient that comes to a hospital, usually some patient will encounter with some infection. If we take that nosocomial infection, the top category usually goes to the urinary tract infection, that constitutes 33%. The second is the other category, that constitute about 25%. These include usually a lung infection in the form of basal atelectasis, or usually vein cannula insertion leading to thrombophlebitis infection. All these come into the other categories. Or some third category, third is the our topic, that is surgical site infection, which is the third most common nosocomial infection, which constitutes about 23%. The percentage usually varies. Though surgical site infection is the third most common among the surgical patients, it is the most common. That is, highest is top. Any patient admitted for surgery or surgical related case, surgical site infection is the most common, accounting for 40% of healthcare associated infection. Among them, 67% usually are of those of incisional infection, that is confined to the operative incision, and 33% are usually because of the organ or space infection. I'll be addressing those in detail. So, what is the organism that causes surgical site infection? I am putting one slide purely because it is a multiple choice question. It is the Staphylococcus aureus is the most common pathogen usually that causes surgical site infection. These are usually normal microbial commensals of the skin, that once an incision is made, usually the patient will get this type of infection. But if it is a clean contaminated or contaminated procedure where a viscous is open, in such case E. coli is the common organism. So there are two organisms that I have mentioned. So there are certain surgical site infection depending upon the different site. There is three types, that is superficial incisional, deep incisional, and a deeper organ specific. Superficial incisional incision involves only the superficial epidermal layers, means the infection usually are limited to the superficial epidermal layers. So deep incisional is nothing but the infection usually limits to the subcutaneous tissue and muscular compartment or maximum facial layers. Deep or organ specific can involve the organs. If a laparotomy has been done, there is a intra-abdominal abscess collection post-operatively, then those are usually termed as organ specific or deep space infections. So this is a picture which clearly shows the superficial infection, where the infection usually is confined up to the skin and subcutaneous tissue only, and the same infection is epidermis only, and if that same infection is extended deep down, it usually is confined up to the muscular component. It is what we term it as deep incisional infection. If that same infection is spread to the deep organ space, so we term it as organ space infection. So what are the sources? Source, as I told, like the source can be an exogenous source from trauma, wound from the environment, or it can be operative wound when there is plenty of movement of people in the operation theater, usually from the air or instruments. If the instruments are not sterilized properly, again chances of infection from the exogenous source. The endogenous source can be a primary endogenous, where the patient's own indigenous microflora are the common source of infection, or secondary endogenous, where microbes colonize the patient in the hospital. So patient is admitted one day before in the hospital for elective surgery, patient acquires hospital infection, and that infection will lead to secondary endogenous infection. So endogenous in surgical site infection are the majority of causes of surgical site infection, among which, as I told, Staph aureus and Coagulase negative are the most common organisms, which are usually present as a skin microbial flora. These are introduced directly after making a small incision. They are directly introduced into the incision. Though cleaning and skin degerming are useful, but when the colony is heavy, like the bacterial colonies are heavy, or if the the site is unclean, in such cases these bacteria predominate and they cause surgical site infection. There are exogenous sources also, that from direct inoculation from the surgeon, or it can be from the hair or scalp, it can be from the surgical mask unless hood is present, and face and nostril, and increased stocking also usually as a droplets can cause surgical site infection. Very few outbreaks have been seen. There are certain factors. We have to know what are the factors that favors surgical site infection. There are certain local factors and general factors. Local factors will be skin injuries in the size and depth of the wound. This is purely the classification wound, which I am going to tell you. Depending upon the different type of surgical wound, patient get surgical site infection. There is different percentage of getting surgical site infection for different surgeries. And more importantly, it is the concentration of the bacteria. If the bacterial concentration is high, there is direct correlation to the surgical site infection. So other general factors are age. Extremes of age usually have high chance of wound infection, and if the patient already has an underlying comorbid condition, it can be in the form of patient immunosuppressive therapy, or patient is a diabetes, uncontrolled diabetes, or patient is anemia, and alcoholism, allergy, jaundice and uremia are the certain condition which will usually cause surgical site infection. Other factors favoring are microorganisms. Definitely the microorganism is the one. If the count of the organism is more, that is overpowers the host defense, it's going to cause wound infection. If the virulence of the organism is more, it's going to again empower the host defense barrier, and it's going to cause infection. The toxins, the exotoxin and endotoxin are the one which cause usually the septic shock, which has been discussed in detail in my class of septic shock, how they are taken up by the host defenses by the damp as well as the tall receptors, and cause the cascade of activating the cellular as a complement system or activation, which leads to cellular damage at the tissue level and also at the microvascular level, and cause tissue ischemia. The other factors favoring are the macroorganism. The macroorganism are the one that are purely the host defense. There are certain host defenses of particular body that I'll be just highlighting. The skin host defenses is mainly by the antimicrobial substance secreted by the sebaceous gland that prevent the bacterial invasion, and the normal commensals of the bacteria. Yes, the normal commensal that cause the most common surgical site infection, Staph aureus, they have a preventive role by colonization resistance from other organisms. So the other organisms do not enter into the body, and this is mainly by the term called as colonization resistance that specifically occurs at the skin level. So this is how the skin is prevented from entering of other bacteria by secreting different antimicrobial substance. In the respiratory system, it is mainly by the respiratory mucus and the alveolar macrophages that have property of killing the bacteria by trapping into the mucus, and also by the phagocytosis by the alveolar macrophages. In the gut, usually it is mainly because of the lactoferrin and the transferrin. These lactoferrin and transferrin, they sequester the microbial growth factor ion, and also the fibrinogen, which traps microbes and polymerizes them to the fibrin. A specific immunity, that is cellular and humoral, that is cellular is mainly by the macrophages, secrete tumor necrosis factor alpha, interferon gamma, and interleukin 1 beta 6 and 8, which have cell signaling activity, and also destroy the entering microbes. The complement systems or the humoral system also act by the process of opsonization, and also by the activation of the membrane attack complex. So there are different host mechanism or host barrier mechanism occurring in the human body at different system levels. So when these system levels or the barriers are broken by the organisms, then there is infection. This slide purely tells the percentage. The Staphylococcus aureus and Coagulase negative tops the chart with high wound infection, and Coagulase E. coli usually in the clean contaminated cases. Classification of the wound infection, it has been classified into class 1, class 2, class 3 and class 4, depending upon clean surgery to the class 4 called as dirty surgery, where there is already spillage. The right column shows the percentage of wound infection in different types of classes of surgery. This percentage is very important to understand. One, because it has been asked plenty of times in multiple choice question, because it can be asked in the form of class 3, what is the percentage of infection. And second important thing about this percentage is, post-operatively, even if you see in clean cases, the percentage of wound infection is 1 to 2%. So post-operatively, you should expect 2% of the patients still having infection in clean cases. As the class increases, that is class 2, class 3, the percentage usually goes high. So post-operatively, patient hospital stay will be increased, the cost of antibiotic will be increased. There are plenty of factors that needs to be addressed with this percentage that goes with the counseling of the patient. I'll be just briefing. Class 1 is hernia surgery with breast biopsy, where percentage is 1 to 2%. Clean but contaminated, where cholecystectomy, elective surgeries, where the patient is being planned for elective surgery, the incidence is up to 1 to 9.5%. Clean contaminated, where colorectal surgery is there, usually the percentage goes to high because of the high colonization of the bacteria. The contaminated is where the bowel is opened, okay, where there is enterotomy has been done, where there is an injury to the large area of the tissue. In such cases, the percentage is up to 13.2. Class 4, where there is already spillage like perforated diverticulitis, necrotizing soft tissue infection, the percentage is up to 12.8%. This is from the textbook of Schwartz. There is one more classification which I have taken from the textbook of Bailey and Love, which is the latest edition. He gives into clean contaminated, where viscous is opened with minimal spillage. Best example is open appendectomy. Contaminated is when there is a open viscous with spillage or inflammatory disease, okay, and means elective surgery for bowel preparation, where you do resection and anastomosis can be the best example. And dirty, where there is perforation which has already occurred and a lot of spillage has taken place already. If you see, the percentage of infection rate is different. So multiple choice question, it goes which is closer to your percentage, that should be given the correct answer. Here clean is up to 2%, which is same as that of Schwartz textbook of surgery. Clean contaminated, the percentage he sees roughly less than 10%, but contaminated is going up to 20%. Dirty wound is less than 40%. 40 is a significant number to say patient up to 100 patient operated, 40% or less than 40% there are chances of getting wound infection. The number is significant, is what I am trying to say. So once a wound inspection has been categorized, type of wound has been categorized, post-operatively there are patient will develop infection. That infection should be graded. There are two grading system. One is Southampton scoring system, and second is the ASEPSIS wound score. Southampton scoring system is only 1, 2, 3 and 4, and last is the 5, where there is deep or severe wound infection with or without tissue breakdown, but hematoma requiring aspiration. So if you see 1, 2, 3, 4, 1 is a process of normal healing. Usually normal healing takes place because it is just a mild bruising that is taking place in the wound. In 2, it is associated with minor complication but does not require any intervention. They usually heal upon their own because it is just a hemoserous discharge of less than 2 cm. If you go for the 3, usually it is a wound infection which comes under grade 4 or grade 5, and patient has to be addressed with higher antibiotic or change of antibiotics. So major complications are usually the pus formation and hematoma formation. If there is a hematoma formation which occurs in major complications, such patient will definitely require some surgical intervention. So 1 heals by normal process, 2 is minor complication, does not require any intervention but heals slowly, and 3, 4, 5 usually 3 requires antibiotics, 4 and 5 usually require some surgical intervention to drain the pus or evacuation of the hematoma. ASEPSIS scoring system is purely, this is, you can see ASEPSIS itself is, A is additional treatment, S is serous discharge, erythema, purulent discharge, separation of tissues, isolation of the bacteria from the wound, or patient stays extended for 14 days. So these scorings have been given to this ASEPSIS. If the score is usually 0 to 10, it indicates there is a satisfactory healing. If the score is 11 to 20, there is disturbance of wound healing. The wound may not heal properly or may not be a healthy scar. If the score is 20 to 30, so there is minor wound infection. 31 to 40 score, moderate wound infection. More than 40, severe wound infection. So this is how the wound score has been classified. So this is the end of the class for surgical site infection, that includes up to the classification and the grading of wound infection. Next class I'll be addressing upon the continuation, that is specific surgical site infection. Thank you.